Our goal today is to do a couple of things, is to hear from you, first of all, to hear from you and to gain a better understanding of how to best approach the next round of immigrant and refugee stakeholder advocacy contracts. More specifically, what type of advocacy events should we focus on for these contracts? And how do we determine where the real need is? And so we're looking forward to hearing your feedback today. These contracts are a part of the Commission's efforts to support the critical and current mental health needs of the most impacted immigrant and refugee communities. Before we jump in, I did want to pause and provide a little bit of background before we get into any of the specific questions. The Commission provides funding to organizations that advocate on behalf of 8 specific populations who have traditionally been unserved or underserved in our mental health system. These populations are consumers, diverse racial and ethnic communities, family members of consumers, LGBTQ communities, parents and caregivers, transition age youth, veterans, and immigrant and refugee communities who we're going to be focusing on today. So the Commission's budget includes about just a little over $2 million in funding for competitive bid contracts to support mental health advocacy on behalf of immigrant and refugee populations. So the intent of this funding is to ensure that there is meaningful stakeholder involvement at both the state and local level. So these contracts focus efforts primarily on training and education, outreach and engagement, and advocacy for relevant and effective mental health services. So the first round of funding was approved back in 2018. After an extensive community listening session process, some of you might have been at some of our stops. The Commission approved funding for 5 advocacy contracts, 5 local level organizations, each located in one of the 5 mental health regions in California, were awarded contracts to support immigrant and refugee organizations. Some information was sent out earlier through our listserv about those 5 organizations. And it's on our website right now if you're interested in looking at it at mhsoac.ca.gov. So the contracted organizations focused their advocacy activities in the following areas. First, connecting with and informing local level decision makers on the needs of their stakeholder population, providing culturally competent training to local area service providers, holding roundtables to stay engaged and connected with community members, and responding to the immediate COVID-related needs at the height of the pandemic. So these contracts will be ending on June 30th of 2022. And so in anticipation of that, the Commission is preparing to release a request for proposal for the next round of funding for immigrant refugee advocacy. So we anticipate that the next RFP will be released early in 2022. So with that, that's a bit of the background. I'd like to shift to providing a little housekeeping and the procedures for today's listening session. We want to hear from as many of you as possible, so we want to make sure you understand how to raise your hand and be able to speak and how we do that. So some of you may not be familiar with the procedures for making public comments, so we'll explain the process here. So please raise your hand if you'd like to make a comment. We'll take comments in order that hands are raised. You may raise your hand to make comment by clicking the raise hand icon on your computer or the app, or if you're calling in by phone, it's *9 to raise your hand. You'll be placed in the queue for comment, and when it's your turn to comment, we'll call your name, or if you're on your phone, it'll be the last 3 digits of your phone number, and then you can unmute yourself and speak. So there's no time limit to speak, but please be mindful of other participants waiting to comment as well. Please take the opportunity to share your thoughts, but also make space for others to do the same. We'll do our best to stay focused on the questions that were provided in the agenda for today's meeting. So with that, let's begin. Our discussion today will be guided by three main questions that like I said, are on the agenda. I'll introduce the question and then ask for input from our participants. And if you have questions for us about the process throughout this process today, we're happy to address them as best we can. Does that sound good? Okay. Lester, do we have the agenda up? Can we put the agenda up on the screen?
Yes.
Or the question anyway. Let me just ask the first question, but maybe we can put it up on the screen if we could. That would be good. So the first question we want to ask today, and this may take up a lot of our time. The first question is, what are the current challenges in your communities, and what advocacy tasks are most important in addressing those challenges? So what are the current challenges or barriers, I guess we could say, in your communities or in the immigrant and refugee communities that you're involved with? And what advocacy tasks are most important in addressing those challenges? And hopefully soon we'll be able to get that question up so we can all see it. Anybody have any initial thoughts? I see one hand up. Okay, good. Yeah, feel free to, if you have thoughts on that, feel free to raise your hand. Let's start with Gulshan. Go ahead, you can make your comment, take yourself off mute. Gulshan Yusufzai. I'm sorry, I may have mispronounced that. Gulshan? You'll have to unmute yourself. We can't hear you if you're trying to speak. All right, let's go to Ignacio. Ignacio Gonzalez.
Hello, yeah, here. So I work for SCRS, an independent living center in Southern California, Downey. We deal with obviously people with disabilities, and a lot of times they have a whole host of issues aside from mental health. And in some cases, they may feel like, mental health is just the least of my concerns right now. I mean, I need housing, I need assistive technology equipment, I need, my benefits are being cut, or on and on and on. So I guess our challenge is how to prioritize mental health over other things that are more pressing, right? I mean, they need food, they need CalFresh, they need things that are more pressing. So our challenge is to let people know that, look, you need to have your mental affairs in order. So in order to tackle all your challenges, and I don't know if anybody else can chime in as to how you have people prioritize mental health.
Yeah, it's a great comment, great question. Thank you. I think we're going to be doing a lot of hearkening back to our listening sessions that we did a few years ago. But this definitely came up, and what comes to mind right now for me is hearing about the legal needs for legal advice and counsel for immigrants and refugees to receive the services and the help that they need. And so that's one of those things that it's like, well, we'd like to give you mental health services, but others are thinking what I really need is an immigration attorney that's available to me. And so that's a good point. And I do think, we remember hearing that. We do have some of our current stakeholder contractors on the call, it looks like today, and some of them may want to comment on that about, what we do in terms of providing services that are not necessarily mental health or clinical related. But thank you for the question. Gulshan, not sure if you've been able to get yourself off mute there. I can send a message to you to ask you to unmute yourself if you're available. Otherwise, we'll go to Alberto Perez.
Hello, can you hear me?
Yes.
So my name is Alberto. I'm the program manager for Cultura y Bienestar at La Clínica de la Raza in Oakland. And looking at the question, there's so many things, but two things come to mind immediately. And one of them is language access for indigenous speaking communities. We have had an increase in the number of non-Spanish speaking immigrants in our area, many of them bringing a lot of issues of trauma and having experienced a lot of discrimination and racism in their countries of origin, and then experiencing similar issues here in this country and all the implications that it has for their mental health. And there not being enough service providers who speak the language, peer educators who speak the language, and or interpreters who speak the language. And I do know that's a similar case in San Francisco with Mayan speaking communities, and as well as, I don't want to speak for others, but I do know the Central Valley has an influx of other languages. And so those things in terms of immigrants and refugees are things that always concern me. And I would like to see some efforts put into language access, workforce development to meet that need. And then the other piece I was going to say is, you already alluded to it a little bit, Tom, which is the impact of the pandemic in the mental health of our communities and measuring it, quantifying it. I think we're having a bit of trouble with that because we're not set up for it. And we know, because we see it on the everyday work that we do, that there's been a major impact. Ignacio just spoke a little bit about issues like, food security and housing and things like that. And mental health is impacted by all of those issues. But I don't think there's been a serious effort to measure the extent of the issue. And I'll leave it like that because I know others want to comment too. Thank you.
Hi, Tom. Can you hear me? This is Gulshan.
Oh, hi, Gulshan. Yes, we can hear you. Go ahead. Glad you made it back.
Sorry about that. For some reason, I could not mute. I kept on saying the host is not allowing it. So can you hear me okay now?
Yeah, we can hear you.
Okay, wonderful. All right. So you asked about the challenges for the refugees that have come in, right? Is that the question?
Right. Yes.
Okay. Yeah. So I'm the executive director of a nonprofit called Muslim American Society Social Services Foundation, and we primarily for the last 14 years have been working with Middle Eastern, South Asian, North African community, which includes a large number of Afghans, Afghan refugees, and we provide mental health services in 5 languages, including peer and clinical. And I myself, actually, I'm Afghan, and I came to the Afghan process when I was a kid. The first time the U.S. went into Afghanistan. But from what I've seen at MassSAF and the last so many years that the refugees have come in terms of challenges, clearly everyone knows that language is the major issue. And so when the SIVs came in around the 2014, since they work with the US government, they at least were able to communicate. But now the high numbers that are coming in that are not SIVs, that's going to be a huge issue. So that's clearly one issue that in terms of settling in here in the US. And what we've seen at MassSAF is that the initial 90 days when they are resettled by the resettlement agencies. That's the first challenge, an immediate challenge. However, the major issues start after that. So therefore, we get many cases from refugees regarding domestic violence. In fact, we just opened up the first Muslim, we're one of the 5 agencies that opened the first Muslim women's shelter, domestic violence shelter. So DV is a huge issue, also issues with regards to substance abuse because of what happens back home. And then, of course, the various issues with regards to integrating, which we all know happens when you're in a whole new country. But then the other issue is about employment. We all know part of our wellness is employment. So that's a huge issue for the community. There are many others that we have encountered, but for the sake of time, I'm just going to stop now and I'll share later.
Okay, well, great, thank you. Yeah, feel free to loop back around and share again later. Clint Carney, go ahead.
Okay, thank you very much. And thanks for holding this session. It's great to have the opportunity to speak. My name is Clint Carney. I work with an organization in San Diego called Survivors of Torture International. And we, mental health, of course, is a huge part of the direct services that we provide. But we serve survivors of state-sponsored, politically motivated torture from all over the world. More than 90 countries, speak more than 60 languages. And a big challenge of ours with policymakers and some decision makers is sometimes explaining and educating on the differences between different types of people from other countries with different status. So you have refugees, but not only teaching the differences between asylum seekers, refugees, and asylees, but also the subset of asylum seekers that we work with torture survivors. So education and advocacy are really important to the work that we do. The Office of Refugee Resettlement has recognized that 44% of refugees, asylum seekers, and asylees are survivors of torture, which is a huge number. And we're talking about severe trauma, complex trauma. So our advocacy efforts are really important, but we're not the only organization doing this work. There are 6 torture treatment centers in California, and collectively, we all work together and share best practices, but we also advocate together. So it's really important, I think, we believe to have an advocacy program that has like a statewide focus and not really just at the local level, because we have a lot of issues that definitely have statewide importance. And we would want to see these grants and this type of advocacy program to allow for statewide advocacy as well. So that's all I have for now, but I appreciate the time very much.
Great. Yeah, thank you, Clint. Stacy Hiramoto.
Sorry, I just wanted to know, is there a period where we can ask questions about technical aspects? Because this is very valuable time where I want people to be able to talk about the problems, but I have questions such as the one I put in the chat.
Yeah.
And then I also have some comments, and I'll hold if there's going to be space for those, but otherwise I'll just ask them now.
Yeah, you're asking if these comments are going to be available to view prior to the RFP being released. Is that your question? That's
one of them, the comments and the questions and the answers that the OAC, if there are answers,
yeah, will
there be a place to view those?
We're recording this session, and so what we'll do is we also have people taking notes as well. So we'll have the recording transcribed, and that'll be available to view because we're going to have other opportunities for public comment on the RFP process, and so it'll be available prior to that. Yeah.
Okay. Thank you. And then can people submit written questions or comments, and will you also put those in writing before the RFP, or is that only after the RFP comes out?
Yeah, we typically have a question answer period, but you're specifically asking prior to an RFP. Like if people have specific questions now, Yeah, those questions can be asked here. We can do our best to answer them. We may not be able to answer everything. Really, primarily, this is for us to listen and get as much input from the public as possible.
Okay, no, I had some colleagues that were not able to make this, and they said, "Well, can I?" But then you know, they didn't know. Are you going to answer? You know, or are they going to be written where other people can see them too? You see what I mean?
I think that's something we could do. If people want to send in questions, if you're even in here today and you had a question, then feel free to submit it. Or if you're not here and you know somebody who has a question, you can submit it to our main email, mhsoac@mhsoac.ca.gov.
Thank you. We really appreciate this, Tom, that for this opportunity, and we really want to thank the OAC for this. And the last comment I have is that I really suggest, again, because even though we really appreciate this, and I know you haven't even started on the RFP yet, I just would like to mention that it might be a good idea for the OAC's Cultural and Linguistic Competence Committee to weigh in on some of this, because they'll be meeting, I'm assuming, you know, before the end of the year. And I think that those individuals are very good people from the community and would have a lot of things to say. So that's just a suggestion. I'm not asking for but it's a suggestion. So
I imagine I imagine this topic will be brought up at a CLCC meeting in the future. The next CLCC meeting will be November 10th from 3 to 5:30.
Thank you. Thank you so much.
All right. Hector Ramirez.
Hello, good evening. My name is Hector Ramirez. I'm from Los Angeles County, consumer from Los Angeles County Department of Mental Health. I really wanted to thank you for this particular question, having followed up the original MHSA project. And I really, just based on the comments that everybody has already provided, I think one of the major challenges for our community right now still is representation, particularly in decision bodies or even stakeholder events, because of a variety of challenges, both that can include lack of linguistic access, disability accommodations, and definitely the necessary support for some of these stakeholders to really be at the table, particularly around issues around peer certification. One of the things that we've heard so far is the need for capacity and to expand services to our most impacted communities and most significantly disadvantaged. Definitely looking at our Afghan refugees right now during this high need of service, looking at them, for example, some of those most high needs communities, but some of the most significantly marginalized also. Some of our refugees, immigrants, or undocumented immigrants from the American continent oftentimes really receive a certain degree of secondary attention. And that really oftentimes creates a significant amount of backlog and inaccessibility factors that significantly impact access to people's benefits, particularly around right now to COVID. We're hearing, for example, in LA County that because of the lack of linguistic accessibility, particularly to our indigenous communities from the Americas who have migrated or are seeking asylum, that being able to access mental health services, at least from our county, posed to be significantly challenged because of the challenges that I mentioned. So that's definitely one of the things that I want to report from the largest county in the US as our undocumented and immigrant communities struggle to survive during this pandemic.
Yeah, great, thank you, Hector. Rosa Flores.
Hi, good evening, or good afternoon. Feels like evening.
Almost.
Rosa Flores with the Latino Coalition for a Healthy California. Thank you so much for this opportunity. Echoing a lot of what folks are saying around language access, cultural competence. I wanted to add one other point in cultural competence outside of the language component, which is really important. It's just understanding the vulnerabilities of the population, particularly when folks have a background, have experienced traumatic experiences, we've heard instances of providers, oversimplifying the immigrant experience and then it resulting in folks not coming back for services. So we really encourage investments in workforce development. On the topic of workforce development, we're really hearing the need for support and navigation of services and incorporating community health workers and promotores into the delivery of services so that it is outreach is comprehensive in language and so on and so forth. And then lastly, I'll share a little bit about what we've been hearing on more education and information on access to psychiatric evaluations for folks that are looking to obtain an adjustment of status into more permanent status and avoid separation of families. I think the importance of psychiatric evaluations is sometimes overlooked, and it can often determine, it can completely turn around someone's immigration case. So I think it would be fantastic if we could look into those investments. Thank you so much for the opportunity.
Rosa, thank you. I'm not sure I completely understand the connection between psychiatric evaluations and immigration. Could you talk a little bit more about that?
Yeah, so I'm not an attorney. I'll speak with a program that we are running here in Sacramento with attorneys, immigration attorneys, and we received funding through a foundation that would allow us to provide folks living in Sacramento who were looking to obtain permanent status with funding for a psychiatric evaluation, which runs, we heard around $500 per evaluation, and it helps support someone's immigration case when they're going in front of an audience or a judge. And so essentially, in a lot of times, those resources were used to keep families together when, families were going to be separated. And we found that there isn't enough information on those kinds of resources for families and individuals.
Okay, thank you. Let's see. Hatafas, the Cambodian Family, I believe. I'm sorry, I'm probably not pronouncing that correctly. I can only see part of it on my screen.
No worries. Thank you very much, Tom. Hi, everyone. My name is Hatifas. I am from the Cambodian Family Community Center. We are in Santa Ana, which is in Orange County. So we are the only Cambodian serving nonprofit organization based in Orange County. And a lot of our work revolves around prevention, early intervention related to mental health. And some of the things that we do see occurring within our community, like a lot of folks have been echoing, is language access and culturally appropriate mental health care. And how do we ensure that these services are adequate for our community members? So one of the examples is, so for the Cambodian community, since the Khmer language is not considered a language threshold according to the state of California, therefore within Orange County, the Khmer language is not considered a threshold language. So a lot of our community members, as they would like to seek mental health services, oftentimes a lot of our case managers are having to be a part of the therapy sessions, or oftentimes a lot of our community members cannot find therapists that are speaking within the language. Also, in terms of advocacy, so I have been really proud of the Cambodian speaking community. Although they are monolingual and limited English speaking, they do attend meetings and voice out that they do need these services as well in language. So that is a component that's very helpful. And I think one thing to keep in mind is that when kind of creating services for the community members, there's a lot of re-traumatization that does happen when it comes to providing these services. So I would say if there's a way to somehow for agencies that are contracted to receive to make sure that these programs are appropriate in terms of healing the mental health process, not the continuation of re-traumatization. And then also, I had another comment related to the next question, but I can wait until the next question. Okay. In terms of data collection. But the big components, as everyone has been mentioning, would be the language access and appropriate care for the community members that are monolingual speaking. Thank you very much.
Yeah, thank you. Yeah, that seems like it's emerging as a common thread through a lot of the different communities. Thank you. Nina Moreno.
Yes, hi, good afternoon, Dr. Nina Moreno. I'm the Director of Research and Strategic Partnerships at Safe Passages. And first, I just want to thank the Oversight and Accountability Commission for this opportunity. I wrote up a couple of talking points. A few of them uplift comments that some of my former colleagues on this call have already made. I'll start with those and then I'll get into just a couple of others. The first thing I want to say is that immigrant and refugee communities need equitable access to factual information that is culturally, linguistically, and developmentally appropriate. And when I say developmentally, I think oftentimes we, think of, youth and adults, children, youth, and adults, but I think we have to remember that 0 to 5 age range. The other piece that I want to say is that, and folks have already said this, just the importance and need for access and investments by city and county governments, as well as state governments, in community-defined, culturally relevant practices that address mental health disparities in immigrant and refugee communities. I'm in essence referring to cultural practices that resonate with these communities. The other thing that I wanted to say beyond those points is that, well, actually, this is a third point that folks have already spoken to, just the importance of investment in culturally and linguistically relevant mental health pipeline of, peer-to-peer mental health providers like the Promotora model. That's one of many models that are out there. I mean, these folks are the gatekeepers to, these two communities. And I just think, city, county, and state government needs to invest in a pipeline that will produce these professionals and invest in these kinds of pipelines. I just want to make just a few other points. A lot of nonprofits on the ground are already doing this work that I just talked about. And so, I strongly, just urge that the next round of funding considers those groups. And also, I just want to say that I think there's, beyond the city and counties investing in, the areas I just talked about, I think there's a role for government to invest in those areas. And let's see here, I think those are most of my talking points, but I had one additional thought that I thought of as colleagues were speaking on this call before me. And that is my hope is that in terms of process that, there are folks reviewing these applications and part of the decision-making process, that there are immigrants and refugees on that panel of people who are reviewing and making decisions about who will be funded. I think they bring a unique perspective and they should be a part of the process of choosing who gets funded. Thank you very much.
Thank you, Nina. Appreciate it. Senate, African Coalition.
Hi, good afternoon, everyone. Thank you for the opportunity. I think everybody shared. As an immigrant refugee community, we share a lot of challenges, what did the presenters say. But one thing I have to say is what's the challenge in our community is a trust. Trust is the basic and the foundation of our community. Because of that, they've been marginalized. In other words, there's a lot of traditional services in the city, in the county. Not like we don't have a direct service, mental health or any other service. The problem is it's only one way to serve the community. That's a big issue. So when we identify immigrant refugees, has to be inclusive. That is like Western Europeans, Asians, Africans, and Latinos. Which part of the immigrant refugee as marginalized is the best thing to evaluate, assess, and that's why we had to be ethnic-based, community-based organization or service providers. Within that, there should be an equity to serve both immigrant, refugee, and they're the same opportunity. So that's why the advocacy comes. Although we all are immigrant refugees, but depends which part of the world came is what the issue is. So the major issue is equity. So the advocacy has to take place state, county, and local level to have an equity service. And that's what we've been doing. As I said, I don't have to go back to the challenges and everybody said it, but how do we advocate is mainly focus. So this opportunity, this grant's been working with us to empower and build the capacity for advocacy. And then not only mental health, as you say, Tom, some other services, that leads to the mental health issue. So that's what we're gonna be doing. And we hope to acknowledge that issue with immigrant refugee beyond the day-to-day access or services. We have to make a fundamental change with equity service. Thank you.
Great, thank you, Sinead. Jorge, go ahead. Jorge Monzon. Oh, you're on mute, Jorge. Can you take yourself off? There you go.
Yes, good afternoon. I'm Jorge Monzon with Alivio Telehealth. We have been working with Dr. Diaz and other doctors and medical students trying to provide health and mental health services to the migrant communities. And what we find is basically an issue of not having enough trained clinicians or trained interpreters to do the communication gap between our LEP communities and our providers. To begin with, we're in a bottleneck because we're not graduating enough doctors and clinicians and social workers that are bilingual. So the best next thing that we have with us is to train medical interpreters to do the work, because most medical interpreters necessarily, they have not been necessarily trained as behavioral health interpreters. And it's quite different when you consider the different stressors that we find in our LEP communities, our migrant communities. So our recommendation and what we have been doing in a very organic way is to basically train interpreters to provide that bridge of communication between our monolingual providers that mostly speak English and our populations, which also include people that come from other towns, indigenous towns, that speak Quechua, Pocomam, Triqui, and any other languages that we haven't seen here. Many of these folks don't even speak Spanish, much less English. So I think that the effort should be considered on training the new pipeline of healthcare workers and also having proper interpretations, code of ethics, and everything else that comes along with interpreting for behavioral health. So I just hope that that is something that is considered, because it's not just a matter of having the services, it's who is going to be able to interpret properly in the cultural space that we need to do. And that's all I'm going to say. Thank you.
Think you're on mute, Tom.
Sorry, that's why you couldn't hear me. Basim Chaudhary. Thank you, Lester.
Hello, everyone. My name is Basim Chaudhary. I am 25 years old. I'm representing Mass SSF. And what I want to talk about is regarding the youth. We know many of these immigrant refugee families will be bringing their kids along with them. And so the youth are also, something that we should, really emphasize, especially the Afghan refugees that will be coming, especially in Sacramento. They're going to have to face a lot of the linguistic barriers and cultural competency barriers. And these are youth who have, who have been in a war-torn country, right? Seeing war, having, family members who have probably lost their lives, and then expecting them to sit in a desk in a confined classroom, hoping that they'll, behave and learn something out of it. But what I want to focus on as an advocacy task would be to help alleviate that stress, the trauma that they've seen, and to help them in their school as best as possible, is to, one, have more peer-to-peer support for youth, and two, if we can have either on-site having those services or having local wellness centers for youth that can support them with their linguistic needs and cultural competency needs, and helping them when it comes to managing that trauma, especially in the classrooms. That's all from me. Thank you very much for the opportunity.
Thank you, Bassett. Clint Carney, go ahead.
Hi, thanks for letting me speak again. I wanted to highlight and thank someone asked a question about psychological evaluations, and I wanted to highlight the importance and how critical psyche evals are in the immigration process, especially with asylum seekers. So asylum seekers, less than 10% of asylum seekers, whether they have an attorney or not, less than 10% have asylum granted. But with our clients, the torture survivors that we work with who are applying for asylum, we coordinate psyche evals, and we've had success of more than 80% of our clients have asylum granted. And a very critical piece of evidence is that psyche eval. So they are extremely important to the immigration process for asylum seekers, for our clients. And it's also kind of another advocacy challenge is to let policymakers know about what are psyche evals and how important are they, and there's a huge difference in having immigration status granted with and without that. So thank you, Tom.
Great, thank you. Thanks for the additional information on that. Amira.
Hi, good afternoon. Thank you so much. My name is Amira Basmi, and I'm the Fund Development Director with Access California Services. We're located in Anaheim, Orange County, and we provide wraparound health and human services with a focus on the Muslim and Arab American community. But in the span of 23 years, we've actually reached out to a huge diverse community of immigrants and refugees, and we're actually funded by the Orange County Social Services Agency since 2011 to be the lead agency for refugee social services, where we work with refugee cash assistance clients to get them to self-sufficiency and get them a job within the first 8 months of arrival. We actually have a mental health department on site, and what we've continuously heard from our clients is, right now, it's really sad. Right now, our priority is that we want a dignified job. We want housing. These are the first things that we need before we can begin. And they don't understand necessarily that probably mental health is the first step to take. But right now, their immediate need is, I need to find an affordable house. And it's so difficult to find affordable housing in California and, of course, Orange County. And I think to address the housing issue, I think there needs to be a lot of education and training for our local landlords, apartment complexes, to really have them understand the needs of the refugee communities. Like, they're not coming with a lot of cash. They don't have any credit to get housing. So just to educate our landlords of what refugees are going through. Similarly to employers, what are refugees coming with? A lot of, unfortunately, the stigma is refugees may be coming uneducated. Refugees might not be knowing English, but one important thing to remember is that a lot of Afghans who are arriving from Afghanistan have worked with the US military, who are very knowledgeable about the English language. So I think we have to break that stigma of refugees not coming with any value to this country, which is unfortunately a lot of the narrative going on right now. And I wanted to just echo briefly on what Basit said from MASS. And we actually have a refugee youth mentoring program on site. And it's sad to see a lot of our refugee youth who are coming in are the ones who are actually taking on these immediate jobs. So instead of wanting to focus on their education, they're having to be a provider for their family. So they're focusing on finding urgent jobs without really going towards their aspirations. And one study that we've done actually in the city of Anaheim is the suspension rates and the disciplinary actions are highest among English language learners. And I think it's important that we also educate our educators and our school systems on what the background of refugees and what they're coming with. As someone mentioned before, the trauma that they're coming with. Maybe the English language capacity for our youth is not as strong, to kind of understand again, to basically to increase refugee awareness. Thank you.
Thank you, Amira. Gulshan.
Yes, hi. Thank you, Tom. So I just want to share something that we've been doing, and then really want to echo what's been said. I just believe it's so important. So I've asked the staff since 2016, really since 2007.
Gulshan, we're having a hard time. We're having a hard time hearing
support
you.
Program, and we have. How about now? Is this better?
Go ahead. Yeah, you were breaking up quite a bit, but go ahead.
All right, my apologies. I was just saying that we have developed a peer support program since 2007, but been funded by the Department of Public Health since 2016. And we have developed a program called Shifa for today, which means healing. It's a peer support program, and we have recruited and trained 68 community members, which speak Arabic, Urdu, and the 2 Afghan languages, and English, of course. But out of those, 20 are Afghan, and it's a community-defined practice. And the reason we did this is because majority, as we all know, of the community members that are from Afghanistan have been in war-torn countries for, they've been born, raised, and gone home there. And majority of them are in that area where they will become clinically ill if they're not already. And we believe that peer support is the way, but that was our belief as MASSF, and we've done an evaluation report on this as well that we just completed. But in addition to that, I just want to share as an African refugee myself that, there's that trust factor of they're not going to be that easily, okay to talk to a psychiatrist and so forth. There has to be someone who knows that, who's Afghan, who it could be more like a buddy, like a peer supporter, versus someone who might be a doctor, although they have a lot of respect for doctors. Majority of the time, that is not something that they're going to respond to. And we've seen this in our work as well, that they'll come for immediate needs, whether it's housing, rent, or whatever. Once it takes them a long time to trust you, and then they start to ask, hey, I have this issue with regards to depression and this and that, domestic violence. That's when they start to open up. But initially, it is very difficult for them because of the stigma, because of the trust. And so just want to encourage the peer support model to be used with regards to serving these individuals. The last thing I want to just share is that what someone else just said a little bit ago about health equity. When COVID happened, there was information sent out to these individuals in Sacramento, which has the highest refugee community in English, and maybe Arabic, I think, was translated. But nothing was kept in mind that these people do not only speak English, majority, not all, but also they cannot understand their own languages and read or write their own language. They understand it and speak it. So we in order to make it more equitable, it has to be done in a way where they understand. So for example, making videos, whatever it takes. I mean, we could come up with lots of different things, but in terms of health equity, I think that's an area that really needs to be focused on. And lastly, something that was said that I think really will help a lot, and it's not done often, is the people who are going to be involved in giving these grants. The committee needs to have people who are actually have lived experience in dealing with individuals that are refugees. So this have been said already. I just want to echo it because it is so important to be able to help these refugees move towards recovery. Thank you.
Thank you. Appreciate it, Gulshan. Goya Yang.
Hi, Tom. How did you know how to say my name? It's so pleasant to hear someone say my name correctly. Thank you so much.
Thank you.
I just want to, echo what a couple of the community members had already said in terms of ensuring that there's culturally and linguistically appropriate mental health services that are also age appropriate for children of immigrant and refugee communities. I just can't emphasize that enough, especially being a child of Hmong refugees myself, and knowing that, we also had to really navigate the service system for our parents, sometimes serve as our parents' confidant, but then also experiencing our own trauma, whether it was at home, at school, or in the neighborhoods. And so, I think in order for us to really be able to, provide prevention and also some intervention is really ensure that we're investing in our young people who are also really, kind of the care providers of our immigrant and refugee parents. I think that's also, may potentially be a creative way to really build that pipeline for bilingual mental health services or service providers as well. Thank you.
Great, thank you. And Dorina Wong.
Yes, thank you. So I'm the policy director at ARI, Asian Resources, Inc., where a direct service provider and provide outreach education and enrollments into public benefit programs and workforce development. In fact, ARI started 40 years ago serving the immigrant and refugee communities in Sacramento. And so I just wanted to everybody has emphasized the need for the cultural and linguistic access. And I think it's particularly, it's important for all communities, all immigrant communities, but for the Asian American, Native Hawaiian, Pacific Islander communities, because we're all kind of thrown into one category and the differences, the history and our immigration experiences, our socioeconomic background, our limited English populations are also different and diverse. We always have, this language needs that are not met. So in terms of advocating, an advocacy issue that we're always having to work on is for the collection and reporting of disaggregated racial, ethnic, and language data so that we can target our populations, whether it's the Chinese population, Thai population, Cambodian population. It helps, really is important and essential for us to be able to tell what is happening within our smaller subpopulations. I think an example of this was, during COVID-19, some of the Native Hawaiian and Pacific Islander communities were thrown into the Asian categories. And so it masks a disproportionate impact that the Native Hawaiian and Pacific Islander communities were experiencing in terms of the high infection and death rates. And so that's just an example of why it's so important that we understand what is happening within the larger Asian American and Native Hawaiian Pacific Islander communities. And then I also wanted to stress, like Gulshan was saying, about the stigma experienced by a lot of members in our communities about seeking mental health or behavioral health services. And so I think the reason it's so important for our CBOs to do kind of the outreach and education is because we're the trusted messengers for our communities, and we can try to, dispel some of the myths and stigma of our communities. And, that's why they have to be, again, echoing the importance of our CBOs to be part of the decision-making process, to provide the input. So thank you.
Yeah, thank you, Dorina. Nese Chow.
Hi, I'm Nese Chow from Healthy House in Merced. In our area, I think, echoing everybody else, culturally and linguistically responsive advocacy is very important, including language access. In our population, we've been actually targeting elders, 50 and older, especially in our Southeast Asian community. With our staff, since we have the staff to speak the languages, we've actually been getting quite a few Southeast Asians reaching out because of themselves or having children, adult children with mental health issues, not being able to understand the system and who to reach out to. And our director always says about talking about the tsunami. We've got quite a few homeless individuals now that we're seeing that are coming from these immigrant populations that are actually reaching out to us. And it seems like it's probably our fastest growing elder population right now that we see in our valley.
Yeah, okay, thank you, Nai.
You are.
And Ji Yang. And then I think maybe after Blythe, we'll have Ji and then Blythe, and then I think we should transition to our next question for today. But Ji, go ahead.
Hi, Tom. Thank you for the opportunity. I'm Ji Yang here with the Hmong Cultural Center. The biggest challenges we see in our community now is the education outreach piece. A lot of our immigrants, because they don't know the term mental health and they don't understand what mental health is. What we've been assessing and educating our community, we can see that a lot of them, they don't understand what it is, and if they don't know what it is, even though we try to help them navigate and get the services and whatnot like that, they're not going to understand. So one of our biggest challenges is educating the community, educating our immigrant refugees, and letting them know that there are services out there that's available for them to to acquire and get help. Dittoing off of everybody else that has shared their challenges, cultural competency, and having service providers, being, I guess you can say, same color, same race, same culture, just so that they're comfortable and they have that trust because somebody looks like them is there, and they'll feel more safe.
Yeah. Great, thank you, G. And then Blythe Raphael.
Hi, folks. Thank you for the opportunity. I'm from the Office of Refugee Health. Pardon me, I joined a little bit late. I wanted to provide a little bit of data for what it looks like in the state right now with incoming refugees and Afghan evacuees. The state of California is expected to resettle approximately 15,000 Afghans in the coming year. That's a large amount of individuals in a very short period of time, during a time in which the resettlement programs were virtually, under the last administration, gutted, with many agencies closing in California and USA-wide. So it's a really challenging time for resettlement agencies overall to even have the capacity to serve this number of individuals that will be coming in. Many coming from obviously very traumatic backgrounds and landing in a place that's very expensive with family members left back behind with many considerations here in terms of just ongoing daily trauma of resettlement and then worrying about family back at home. We can match that with an equal number of persons who are granted asylum, which is approximately 10,000 in California a year. We're one of the largest asylum granting states here. For every one of those 10,000, we probably have triple the number that are asylum seeking cases awaiting adjudication, who are also in need of mental health care services. I'd really like to note that we are going to have some particularly impacted counties in California with Afghan arrivals. Those are Sacramento, San Diego, Los Angeles, and Stanislaus. And we have asylum seeking populations in Los Angeles and San Diego in larger numbers. I would like to echo the colleagues who said, please invest in youth. I'd like to advocate today for the committee to please consider, to please consider that we have resource mapped all of those providers currently providing services in California to Afghans. We have some of them on the call here, like Survivors and MAS SF. I'd like to advocate for those agencies that have been doing an amazing job and access in providing services to those populations in the past, so that they have the resources to increase their capacity to serve the large number of arrivals that are coming in. Another individual spoke to youth. We have asylum seeking youth or other immigrant youth that are put in the position to focus on education because they are helping parents, family navigate or interpreting, and really deserve to have some attention and programs developed in school that would help support them. Investing in paraprofessionals and career laddering and interpretation. This is something I've seen for more than 15 years in the field. There's not enough trauma-informed care, and these peer support models and culturally relevant and appropriate models for communities are really, really important to build. So thank you again for the opportunity to speak to the group and to take the input. I appreciate it.
Great, thank you. Thank you, Blythe. Yeah, with that, I think we'll move on to our second question.
And Tom,
yeah,
before we move on, I just want to let everyone know that we will be saving the chat. We're saving all the comments and insight in the chat for the in consideration for the contracts. And for the new folks who are just joining us, you're able to share your feedback and comments to our website. I'm sorry, our email, mhsoac@mhsoac.ca.gov, and I'll share that in the chat as well. All right, thanks, Tom.
Great, thank you. Blythe, you brought up an interesting point about, in talking about specific regions or specific, you mentioned Stanislaus and Los Angeles, San Diego. In round one, we target funds to specific regions of the state. We've also talked about different age groups here today. And so there's the consideration of targeting specific age groups. Also, there was consideration to target funds for specific populations that are from specific regions of the world. And so this is something else we're thinking about, and any input on that would be appreciated as well. Do we target funds to California regions, or do we target funds to immigrants and refugees from specific regions of the world? So appreciate your comments. Lester, maybe we can bring up question number 2, which is about evaluation. And hopefully we can get some good input on here. What should be measured to determine the success of the immigrant refugee stakeholder contracts? What should we be looking to measure that would demonstrate that the effort has worked or been worth it? So if anybody has any thoughts on that, any evaluators here in the room, please go ahead and raise your hand. And if you have any comments on that, that would be appreciated. What should be measured to determine the success of the immigrant and refugee stakeholder contracts? How do we measure success? Alberto.
I'm not an evaluator, but I would imagine that given what we all just heard from others in terms of workforce development or increasing the pipeline of individuals able to provide culturally and linguistically appropriate services, we should find a way to measure that impact, both in terms of the number of people getting into the pipeline and moving up to the professional ladder, and the impact of this individuals in their communities in terms of access to services, in terms of outcomes, and specifically for me would be in terms of prevention. And I know it's always hard to measure prevention because it's hard to measure things that don't happen, but that's probably a question for the evaluators in the room. But if there's a way to measure the impact in terms of how many people we're preventing from going down into the more severe level of care by increasing capacity in our communities to provide services, that will be fantastic. And one more thing I'll say is, I alluded a little bit in my initial presentation, is the issue of the impact of COVID on our communities and just the fallout in terms of mental health and access to equitable access to services. There isn't really such thing. And so if there's a way in which we can measure first the impact of the pandemic and then the impact of our programs in ensuring that people have access to services, I would love to see that as a way of measuring the impact.
Great, thank you. Yeah, your first comment about workforce is interesting. As we're thinking about peer certification, counties coming on board to implement peer certification programs. And that might be an opportunity to measure, have we grown a more diverse workforce through peer certification? Yeah, thank you. Nina Moreno.
Hello again, Dr. Nina Moreno, Director of Research and Strategic Partnerships at Safe Passages. I think there's a lot here. And by the way, I am an evaluator, so I wasn't prepared to comment on this, but I do have a couple of ideas. I mean, I think there's a lot by way of what we could measure in relationship to immigrants and refugees. I mean, I think the obvious one is, the extent to which their mental health symptoms have decreased, right? That's number one. But I think there are some other areas, the extent to which, they've kind of built out more protective factors. A very interesting one is the extent to which they have future hope. That is a big indicator just for kind of success along the life trajectory. But I want to propose another area of evaluation, and that is of our government systems, and specifically the extent to which they've invested in culture, again, community defined, culturally relevant mental health practices. So those are some of my thoughts for now. Thank you.
Thank you. Hatefas?
Thank you. Sorry, I'm allowing an airplane to pass. Okay, perfect. So Hatefas Diop, community organizer at the Cambodian Family based out of Orange County. So similar to what the previous speaker did mention, so community defined practices is something that I feel like is a very, very important component in terms of measuring immigrant and refugee mental health. And then folks did mention in the chat as well, data disaggregation. That is a very important component, especially when we're looking at, for instance, Southeast Asian mental health. As you all know, the Southeast Asian community was one of the largest communities to be resettled here within the United States. And so even within the Cambodian community and many other Southeast Asians, we have many different ethnic groups, not only just Cambodian and Vietnamese, we also have Mien, Hmong, and myself. I am a Cham indigenous to the regions of Cambodia and Vietnam. However, these ethnic groups are not widely recognized within the census. So definitely I would emphasize the importance of data disaggregation when we're looking at mental health. Thank you.
Great, thank you. Sinead and Masu.
Hi, thank you. Again, I'm from African Coalition. So what we've been doing in the past, this was the vehicle to navigating the system. As I say, the social determinants is what matters. How one's mental well-being be measured by, how many things is very successful, especially for the newcomers. Navigating the system is very important. Therefore, during that navigating the system, we can find out how much people would be able to help, whether it's mental health, immigration, or CDSS or social benefit. Because if we're missing one, it's going to lead to mental illness, right? This is outreaching and education contract. My understanding is prevention. So as we do all that assessing with the basic needs, the mental health well-being will be increased. So in the past, the contract, we're supposed to have signatures, workshops, and that is good, that's outreaching. But during this pandemic, it was being challenging to get that. Instead, it's better to have this one-on-one service, like as everybody else, most of the service providers presented earlier, what service we provide. So how many people enrolled to mental health service or any other thing. Because we have to look at for the immigrant to refugee perspective, what they need. So that would be the best way. The outcome is how many people we help within the report period, or that would be the best for us.
Great, thank you, Sinead. All right, well, good. We've got about 16 minutes left, and so I think we're doing okay. We'll move on to our final question, which is for the upcoming 3-year contracts. What are your thoughts on holding virtual, in-person, and or hybrid advocacy events? Obviously, this question is coming from what we had to all work through with COVID, and so while we had planned, a lot of our contractors had planned to do in-person meetings, they were very successful in shifting to virtual meetings or hybrid meetings. And so we wanted to just stop and ask about that. And I think maybe the sub question under this is, what works best, and what do we potentially lose if we do virtual advocacy, training, outreach, or what do we gain by that? So what are your thoughts on this question about virtual, hybrid, or in-person advocacy, training, and outreach? Specifically for the immigrant and refugee populations. Any thoughts? Yeah, Dorina.
Yes, I think, it has been hard to do in-person events, obviously, especially during the pandemic. Although I think to the extent that now some things are opening up, it would be okay to do a hybrid meetings and events. I think that in some ways what we learned when we had to go to virtual meetings is that we actually could get more participation from more areas, because sometimes people had problems with transportation, but they were able to plug in, to the virtual meetings. And so in that way, I think, trying to maximize the number of people who could participate in these kinds of events is good. So having an in-person option is maybe good, but even having just a virtual option, it did allow, I think, for increased community members to participate. Although there's always the technological challenges, right, with just doing it virtual. That's why I think, if possible, doing a hybrid seemed to be a good combination of the two, as what we found.
Yeah, a hybrid approach. Yeah. Okay, thank you. Stacy?
I just want to say, I think it's kind of hard because we kind of don't know what the situation is with the COVID. I mean, I was really hoping it would be gone by, well, not gone, but that things would be opening up in September. And then we have that Delta variant situation. So I think it's a good question to ask, but I think we have to remain flexible. And the only other thing I wanted to mention was that when you're talking about events, and I think the OAC has done this, so I want to compliment them. think that you have been flexible in allowing really prevention type activities, and not labeling them, you know, come to this mental health fair, because for many immigrant and refugee communities, I know that that might not be appealing. We of course want them to learn about mental health issues and solutions and services, but I think, and again, I think the OAC has been flexible and having activities, whether it's gardening or whether it's whole health or whatever. So again, I want to just encourage that it remain flexible. Thank you.
Yeah, okay, great. Jorge.
Yes, thank you. I think that we need to use the best of both worlds. As Stacy was saying, you know, we like to be done with COVID, but COVID is not done with us yet, right? So what's going to happen, at least in the trainings that we have been doing, we have been adapting to training medical and behavioral healthcare interpreters, especially the ones that deal with the mobile crisis unit or the crisis unit, because many of them have to revert to phone interpretation. And that, of course, doesn't work really well. And the other option is, of course, video remote interpretation. And I think that, at least from what we have seen, the best scenario is to have a hybrid model in which we're able to engage the patients at some point that is accessible to them. Like, say, if we're looking with the migrant workers, we have a project right now in Cortland, California, where we actually go into the site and we enroll the patients, and then we're able to do a follow-up via telehealth. But at some point, you need to have that contact with the patient. I think that to expect that we're going to be engaging a lot of the LEP community through this technology is really asking too much, because most of them don't have necessarily access to the technology. Maybe they have phones, or maybe the phones are not necessarily the most advanced phones. So I think that it's a stretch to think that, at least to train that workforce or to service the community that we need to service, that we're going to do it virtually. I think it needs to be a combination. And then we have gathered some resources and experiences that I'll be glad to share if anybody's interested. Thank you.
Great, thank you. Rob Lane. How are you, Rob? Rob, go ahead. You're still on mute. I don't know if you're trying to.
Oh, there you go. Rob,
there you
sorry about that. Rob
All
Lane
right.
with the California Council of Community Behavioral Health Agencies. I was going to say exactly what Jorge had said, so I'm not going to take up time, but I second what he said. I think that there are communities and age groups and cultures that are not as quick or as easy to adopt digital solutions. And so, you know, a hybrid event would allow us to allow better access without, you know, sort of being tone deaf to the issues around the digital divide. Thank you.
Great, thank you. And Clint.
Hi, Clint Carney again with Survivors of Torture International. You know, I think, my opinion, you can't beat the effectiveness of in-person, but I agree with the other speakers that a hybrid model allows even more participation from more regions. So just wanted to support that thought. Thank you.
Great, thank you, Clint. Hatifas.
Hatifas with the Cambodian Family Community Center. So I think the most effective, as what a lot of folks are saying, would be a hybrid model, given there are many elder communities that maybe not have transportation. However, when doing a hybrid model, I do want to make note of just language requests and language access in terms of that. We want to make sure that we are sensitive of those that are monolingual, non-English speaking. So thank you.
Yeah, thank you. And Amira.
Thank you so much. Amira with Access California Services. I do want to echo what the majority has said, and also for hybrid events, but just to also point out, I do agree with Stacy that we have to continue monitoring the situation. But one thing I do know is that we've recently started some in-person events, and like the response was incredible. They were so excited to come into the office and see one another for different groups that we had. I really feel like the in-person is so much more effective. With regards to our youth, they're definitely ready to go on Zooms and they're more technologically savvy, but also we have to keep in mind that a lot of people, their access to technology is not as great in terms of Wi-Fi or computers or even knowing how to navigate things like Zoom. Thank you.
Yeah, great. Well, thank you. Thank you, everybody. I want to stop and thank Lester Rabancho and Michelle Nottingham. They are doing a lot of work in this and will continue to support this effort. So thank you, Lester and Michelle from our commission staff. I've come away with a few different thoughts from today. First is there's a lot of work to do. There are so many items that were mentioned that where we have a lot of work to do to support the needs of immigrants and refugees. And so the second thing I come away with is I'm very thankful for the commission's leadership in this way to advocate for funds for the immigrant and refugee community specifically. And then thirdly, I'm impressed with all the expertise we have here in this meeting and even for those who aren't in attendance. So that's a very, very good sign. We have a lot of great expertise around the state. So there will be more opportunities to speak into this and to provide your input. And so watch for those to come up. I assume you're on this meeting because you're on our listserv. But if not, make sure to check our website. We will be announcing those other opportunities. We'll have an opportunity coming up at the commission meeting when we discuss the immigrant and refugee outline that we'll put together. As some of you had asked for, we will have this meeting transcribed and then we can provide that. Also, if you have questions, as Lester gave out our email address, you can please email any questions you have or comments about any of the questions we asked today or any other items to mhsoac@mhsoac.ca.gov. And with that, I do see our director, Toby Ewing here. Anything you want to say, Toby? Thanks for joining us.
Just thank everybody. I know your time is important. We appreciate that you stepped away from your day to share your insights and comments with us. We really appreciate it. It helps us make this work better and more impactful.
All right. Well, thanks a lot, everybody. Gave you 4 minutes here. So have a good evening and we'll hope to see you all soon again.